I'm always glad to be invited, especially being around students. I love the energy that you guys have. And so it's good for somebody that's been out for a little while to be around young people and to renew some of that fire that you guys have. So excited to be here. And I was asked to talk about manual therapy, which is a topic I love. I've really enjoyed manual therapy throughout my career. I had a couple professors in PT school that believed manual therapists or therapists that use manual therapy frequently tend to be really passionate about what they do. That really resonated with me, so I've really enjoyed learning about and utilizing manual therapy in my career. Recently, and those of you that are using social media as a networking tool and to get information about therapy are seeing probably a lot of controversy regarding the use of manual therapy. And so when we talk about the hype of manual therapy, I'm starting to think when I was younger in my career, there was a lot of hype around it, meaning that you should learn it, you should use it, you should go to as many manual therapy courses as possible. And my sense is that's shifted a little bit. So I'm going to ask your guys' opinion in a few minutes. But just wanted to introduce myself a bit before we dive into that topic. Allow myself to introduce myself. What movie? What movie? Nicole, I like to do the movie quiz.
Is it Austin Powers?
Yes. Austin Powers. It was like 1999. So, Nicole, you always talk about when you were born in our staff meetings. 04. So this is like the equivalent of like an old black and white movie for me, for Nicole. So someday I'll have to watch some more 90s movies. All right. So yeah, my name is Scott Brown. I'm a physical therapist at Sanford. I've been a physical therapist for 13 years. I graduated from the University of Minnesota. Go Gophers. I suppose we don't have any. Do we have any Gophers online? No. So Britta shook her head really fast. She wasn't having it. So graduated from the U of M in 2007. And we were DPT at that time. I think the DPT at U of M started in the early 2000s. So it was the 4th or 5th class to go through that. I'm from Moorhead, so my wife and I moved back to the Fargo region. I worked at Sanford, South Point, outpatient physical therapy for 4 to 5 years. Then I was a therapist at Sanford Power, which is more sports related. And just recently, I switched roles into the manager position back at Sanford South Point. So I'm doing a lot of administrative type stuff, but still seeing patients about 4 hours a day. And I really enjoy manual therapy, spinal conditions, neck, low back pain, sports injuries when they come along, orthopedics. Is kind of my specialty. So I have my OCS and SCS, certified in dry needling, and currently also director of the Sanford Orthopedic Residency Program. So if any of you have questions about the residency and you're missing out on the residency talk that Gary is doing concurrently with me, feel free to ask about that too. So I love physical therapy. I love my job. I'm very passionate about it. And like I said before, I love the teaching aspect with residents, with students, and just the mentorship part is a big part for me too. Personally, I have 4 kids, married 4 kids. We live in Moorhead. Elena, Eden, Everly, and Tommy, and they're 9, 7, 3, and almost a year. So just like Heather, we just don't sleep ever. And you just drink coffee and you smile and just pretend like everything's fine. And so, Nicole, if my door is ever shut, I'll be in there napping. As Nicole probably also knows, I'm very interested and think it's pretty cool, the personality stuff. So we do it as a staff. If you've done Myers-Briggs, I'm an ENFP, which is a campaigner. If you need an example of a campaigner, it's Michael Scott from The Office. So you can just visualize that. I'm an Enneagram number 3. If you haven't done Enneagram, or Enneagram, I think it's pronounced, I would definitely look into it. We did it as part of a physical therapy course last year at Sanford Power. And there's 9 personality types, and it really helps you dive into more about yourself. And so I'm a number 3. Anybody else online done the Enneagram? Nicole, what are you?
I believe I'm a 7.
7? Do you remember what that is?
Don't off the top of my
Okay,
head.
gotcha. Holly?
It's the adventure. The 7 is the adventure.
The adventure. All right. Anybody else?
Looks like we have a couple of comments in the chat box. We've got a 9 from, I'm going to pronounce this wrong, Kalia, and Renee's 1 and Lindsay's 1.
Okay.
I'm also a 1.
My wife's a 1, so she keeps me organized. What's a 1? What's
Perfectionist.
perfectionist? Yes, makes a lot of sense. Makes a lot of sense for my wife. So she keeps me on task. Campaigners or achievers tend to be a little bit up in the clouds sometimes, so it's a good combo. But what's really cool about the Enneagram in terms of coworkers and significant others, spouses, is there's a lot of information out there about how to interact with the different numbers. So like if your significant other is, like in my example, a 1 and I'm a 3, there's a lot of information out there on how 1s and 3s will do really well together and where they might butt heads. So it gives you that information where you can kind of plan on how to best manage your relationship. So that's me. Also, Strengths Finders, that's another great one to do. And the reason I've kind of given you guys this is as students and in my role now, like these are things that are really good to know, like going into an interview. Some of you may be going into job interviews soon or residency interviews. Like these are good things to dig into prior to going into that process. Strengths Finder is another one. I'm a learner, harmony, and achiever. There's like, 40 strengths, and the assessment shows you what your strengths are. The Enneagram and the Strengths Finder, you can buy the book of each of those things, and usually you get a test with it. It's like 10 or 15 bucks. So definitely something to look into. And the other piece of it, and I know we haven't gotten to manual therapy yet, but we will get there. I think this is really important for students and for therapists to achieve success within a profession. You have to have high emotional intelligence, because a lot of what we do is connecting with patients and connecting with people. And so emotional intelligence, and so your IQ, actually success really hasn't been connected with IQ on a research level. So you could be super smart, but you could be terrible with people. Those people tend to not succeed because they don't have those interpersonal skills. Your personality is important, but it doesn't really change over the course of your life. So it's established when you're in about your early 20s, and then it stays consistent. But the one thing you can change is your emotional intelligence, and this is the book. And if you buy Emotional Intelligence, it has some assessments in there which shows you some things and how to work on improving it. So emotional intelligence can improve. It's a plastic skill versus IQ and personality. So something to really think about as you go forward is how can I improve my emotional intelligence? So that was one. Everybody has unique scores on that one, so I didn't share mine. You may not want to know. But those are like 4 things, little bonus tidbits that I think would be helpful for you guys to look into if you haven't. So Myers-Briggs, Enneagram, Strengths Finder, and Emotional Intelligence. So that's me. And there's the crew. All good. It's all good, but busy. All right, so let's dive into let's not dive into emotional intelligence. We already did. Let's dive into manual therapy and asking for some participation. And this can be positive or negative. What comes to mind when I say manual therapy? What words or emotions? Anybody can chime in, or Holly, will you keep an eye on the chat box for me?
Yep.
I can't see. Can I see the chat box and my PowerPoint at the same time? Is that possible?
Yeah, but it's more difficult. So.
Holly, you'll be the moderator. Will you be the moderator?
Yeah.
All right, cool. Anybody got any words? Oh, wait.
Passive for the patient.
Passive for the patient. That's great. We're going to dive into that a little bit, Samantha. What else, guys? Just throw stuff out there.
Mobilization.
Mobilization. Yeah. Good.
Manipulation.
Manipulation. Heather, is dry needling manual therapy, you think? Heather thinks it is. I can read lips.
Yes, I think it is, but
Yeah.
you know, it's a struggle with insurances and stuff these days. I mean, you're reaching some of that deeper tissue that you're trying to achieve with all the other manual techniques that you're using.
Yeah, absolutely.
We've got arthrokinematics in the chat box.
Cool. Arthrokinematics, yeah. You got to know your arthrokinematics. Or maybe you do. I don't know. We'll talk about that a little bit. Anything else? Any emotions? Does anybody get any emotions when I say manual therapy?
Tired.
Would you say tired? Tell me more.
Transforming.
Transforming. Tell me more about tired.
One of my clinicals, I did a lot of manual therapy, so at the end of the day, like, my arms were just tired.
Yes. Yeah.
I promise it gets better as you use it more and more. You don't get as tired by the end of the week.
Yeah. Strengthen
or
up.
you learn the easier techniques that don't drain you as much.
Mm-hmm. Britta, what were you doing a lot of? Joint mobilization, soft tissue, both?
Both. I was at a clinic that did a lot of mulligan and trigger point release and all sorts of stuff.
Yeah. Thumbs get a workout? Yeah, good. All right, well, I sifted through social media and over the last couple of years that, I could have put a lot of examples of manual therapy. It's a very, if you haven't seen on social media, it's a very controversial topic. There's some people, and maybe a better word is polarizing. So there's social media personalities out there that are sort of reflective of some of the literature as well, that are really opposed to manual therapy. And somebody noted already that it was passive for the patient. And so again, I'll just say social media personalities spend a lot of their time posting information that kind of knocks manual therapy and saying this is just complete trash. We shouldn't be using it with our patients. We should be using more active interventions. And so what I found with students, and this is one thing I didn't mention, is that a friend and I teach a lot of manual therapy courses. What we found over our career is that a lot of young people especially are still really excited about manual therapy. That's why I was kind of curious to ask that question, just kind of see where you guys were at with it, and what you've heard, because there definitely is some pushback against the use of manual therapy. And we'll talk a little bit more about how we have to be careful about how we utilize it, because it can be an intervention. If used too frequently and too passively, it can actually do some harm. So the current hype, I think there's a lot of people that love it, use it a ton, and there's a lot of people that are starting to branch out and really start to speak out against it. But I think there's a middle ground, and that's kind of what we're going to investigate today. So I want to really build up manual therapy today because it's been a big part of my career, and I think we should be utilizing it as a profession. So let's hit some key points here, and I'll give you my case. All right, hold on. There we go. All right, so first of all, manual therapy works. The caveat there is manual therapy is this big term that probably encompasses a lot of different things. So when people say manual therapy, we shouldn't be using manual therapy. It's too passive. We have to remember, okay, what are we talking about here? We already talked about mobilization, manipulation. Does that include massage? Does it include dry needling? Does it include cupping? Does it include strain counter strain? So that's where I think some of this turmoil comes from, is that we're using all these different terms. But when it comes down to it, especially for joint mobilization and manipulation, we have a lot of research that tells us that it works. The other part of this is too, it works, but what I was taught in school is probably not the correct mechanism in which it works. And so I'll be kind of interested to hear from you guys that have started to learn a bit about manual therapy, about how you're being taught mechanisms. So on my slide, when I said manual therapy works, just maybe not how you think it does, we used to think, or we used to be taught, that when we're mobilizing or manipulating a joint, we're doing something to the tissue, we're putting it back in place, we're stretching it and getting it to move normally again because of something we did to the tissue. When we're doing, have you guys heard of A-stim or Graston? Most people have seen that or had it done. The way I was taught when I was certified in A-stim, the way I was taught it worked was that you have adhesions in the tissue in an injured muscle, and by scraping through the normal alignment of the tissue, this adhesion straightens out. And you break down basically that damaged tissue, and it realigns into its normal state. And so what we're finding out more and more, and where a lot of this pushback on manual therapy is coming, is it's not really working as much on the tissue level as we thought, at least in the long term. So if you go to a chiropractor and they say your C5 is out and I'm going to adjust it back into place, that's not really supported by the evidence. That's all theoretical. If you, and some of you may learn in school or see a clinical instructor use SI joint techniques. And when I learned in school, you'd have a rotation in your pelvis, and that could cause some SI joint pain. And so we do a technique to de-rotate that pelvis back into normal alignment. And what we're finding out, again, more and more, is that that actually doesn't happen. It makes sense in theory that the founders of some of these techniques thought that may be happening, but it's just not the case. So we need to, that doesn't mean that we get away from using those techniques, but if we understand more that that isn't happening, but something is happening, and what is that? If we can figure that out, we can utilize manual therapy in an effective way. So I'm going to be referencing this book quite a bit. It's an awesome book because it's very updated, and it's integrating manual therapy and pain neuroscience. So it's using a lot of like the educational principles of pain and explaining why manual therapy can still be a part of a comprehensive treatment plan. So in this book, they talk about manual therapy effects. And what we used to see in school is that this mechanical effect in the upper corner of the slide, that little bubble, that encompassed pretty much all of the manual therapy effects. What we know now is there may be a small mechanical effect on the tissue. So let's say on Monday, Nicole comes into my office and she says, my neck is really stiff. Can you help me? We go back to the room. I find that C5, C6 is really stiff, and I'm going to push on that vertebrae and I'm going to tell her that I'm going to stretch your tissue back to a normal state of movement, or I'm going to kind of push that vertebrae back into a normal alignment, that would be a mechanical effect. Again, we know that that's probably not happening that much, but maybe a little bit. There might be a little bit of short-term improvement in joint mobility. So I don't want to say that it's not mechanical at all, but it's a very small piece of all these different components. So Adrian Lau in this book lists 7 different things for a potential effect. So we have mechanical, we have a hypoalgesic effect, meaning that something happens in the brain where your body senses pain at a lesser level after manual therapy. That's much like taking an ibuprofen when you have a sore shoulder. It has similar effects. Psychosocial, meaning that sometimes just putting your hands on someone and just that power of therapeutic touch changes something in their psyche and they feel better. Neuroplastic changes. Socioeconomic effects. One of the examples in the book is somebody that gets some manual therapy early on, even though the effects may be short-term, you have the opportunity to treat them early on, get them moving, get them feeling a little better, and all of a sudden they do some exercises and then they get back to their normal life. Whereas the person that maybe doesn't go in early, maybe they wait, they don't get any manual therapy, they don't get any physical therapy, and they end up going to their doctor. They might get some medications, they might get some imaging, they might get some injections. And all of these things might end up costing thousands and thousands of dollars, whereas a couple sessions of physical therapy may have taken care of it, especially with effective manual treatment, exercise, and education. Neuromuscular effects, autonomic effects. Again, there's evidence for all of these different components of manual therapy effects. And again, this book by Adrian Lau summarizes all the evidence, but if you start looking at the manual therapy research, you'll find all of these things are supported. A really great study, and this was in 2018 by Joel Bialowski. If you ever read Bialowski's work, it's really in-depth, but his first article came out in about 2009 regarding manual therapy effects, and most recently updated in 2018. And I know this is kind of small. What's really cool about this model is it takes into account all of those effects we just talked about, all of those autonomic, neuromuscular, psychosocial effects, and he added this zone 1 on the left hand of the figure, where basically some of those psychosocial effects take place based on expectation of not only the patient but also the provider. So if the patient comes in, and this is something that I want you guys to remember going into your careers, if the patient comes in and they say, I have been to a chiropractor for my low back and they cracked my back and it was the worst thing I've ever had done. I saw a physical therapist last year and for the same problem, and they did some soft tissue massage and it helped me so much more. Even if your intuition is telling you that this person may benefit from a manipulation more than a little bit of soft tissue work, if you try to manipulate that patient, they probably won't come back and see you, because their expectation in their mind is that manipulation is bad, soft tissue is good. So you have to meet that patient where they're at, and you might have to provide a little bit of soft tissue just to gain their trust, and that'll lead to other things like exercise and education. But we know manual therapy isn't just a biomechanical tissue-based approach now, and so we need to make sure we understand the person sitting in front of us too, which we'll talk about more. So that's really cool. So you really need to listen to your patient and even ask them about their expectations regarding manual therapy before you provide it. We actually have studies that have proved this. One of my favorite studies that Bialowski did was he had 3 groups of people with back pain. First group, they manipulated their back and they said, this is going to help you greatly. You're going to feel way better after we do this. The second group, they said, we're going to do a manipulation. They didn't say it was good or bad. They said, we're just going to do this. And the third group, ring finger, was we're going to do a manipulation. It's probably not going to help, but it's going to make you really sore. There's a small chance it might help, but it's probably not going to help. And the results were in line exactly with what they were told. So if the patient was told they were going to get better, they got better. If they were told they were going to get worse, they got worse. If they weren't told either way, nothing changed. So that power of expectation is so huge in anything that we do, including manual therapy, that to go based off tissue only really doesn't go in line with all of these examples that I'm talking about. But again, I only got 45 minutes to talk. At our manual therapy courses, we might talk about this stuff for 2 or 3 hours. So if you want to dig in further, some really good Saturday night reading, especially if you're having trouble falling asleep, Bialowski's articles. But it's great stuff. It's just very deep. It's very heavy. All right, and I wanted to throw this in, and this is just one example of many of studies that show that manual therapy does work. This is a systematic review. If you've had some orthopedics courses or manual therapy course within your schooling, you've likely gone over some studies that show manual therapy is effective, and that systematic reviews and meta-analyses are the strongest form of research. So we have studies, this is from 2018, that show manipulation and mobilization for treating chronic low back pain is effective, especially in the short term. And so again, you don't need to be too focused on this specific study. Just know that there's a multitude of studies out there that show it's very, very effective in a lot of cases. And also look at number 4 down there, multimodal programs may be a promising option. And that just means that we need to use manual therapy selectively along with other interventions that can work. All right, secondly, so manual therapy works, but we want to use a top-down approach before bottom-up and top-down while bottom-up. And I'll explain this a little bit. We're treating humans with an injury or pain of some sort, what we think is to a tissue, and likely is to a tissue, at least the original injury, but this human also has a brain. At least we hope they do. Sometimes you wonder. But we need to remember that pain processing doesn't just occur in the tissue. If you've done any learning about pain neuroscience education, pain is a very complex process. And so remembering that top-down approach, that means we start treating the brain first by getting to know the person, getting to know their story, and giving them appropriate education based off of what they're telling us, education and guidance, before we start getting into the tissue and start scraping or start poking or start manipulating. And then this is key for manual therapy, top down while bottom up, meaning that when you're doing PAs to the lumbar spine, or when you're doing massage to the hamstring, or when you're sticking a needle in somebody's upper trapezius, it gives you a great opportunity to start educating that patient about their pain, about their diagnosis, using a lot of positive language. Even though we're using a passive intervention at the time, we're utilizing that time to kind of build them up in a positive way, to give reinforcement that they don't have necessarily things that are damaged or things that won't heal. But just remembering that all this processing is going on in the person's brain while you're treating them. And so it's a great opportunity to really dive into education during that time. So top down before bottom up, treat the brain before the tissue. And then when you start treating the tissue, you are also treating the brain at the same time. And we'll dive more into language in a minute. So manual therapy works. Use top down before bottom up, top down while bottom up. And manual therapy with clinical reasoning is greater than manual therapy alone. So our profession has battled with many other professions about treatment techniques themselves. An example is when I started as a PT in 2007, North Dakota, we had recently just won a battle to get manipulation in our Practice Act. And so prior to, it was very difficult for a physical therapist to do manipulation in North Dakota. Another battle that's going on now is dry needling in some states. And again, there's other professions that are battling for it as well. And example would be athletic trainers, being able to manipulate or being able to use dry needling. So what we need to remember is at a certain point, if we want to differentiate our profession, it's not just grabbing a hold of all these different manual therapy techniques. It's using the techniques with sound clinical reasoning. If we're not thinking through why we're using it, we're just doing what anyone could do. I could teach, I could teach my 9-year-old to do A-stim on somebody's leg. I could teach, I probably wouldn't want this, but I could probably teach my 9-year-old how to stick a needle in my upper trap. Might be a little scary, but I think she could do it, right? And I think I could teach, my dad how to manipulate my thoracic spine. In fact, has anybody's friends that aren't PTs or chiropractors or health professionals ever grabbed you around the back and shake you like this? We call it the old college manip. When you grab your buddy and you lift them up and kind of shake them. And then you look at the manual therapy textbooks and that technique is in there. And you're like, oh my gosh, my college roommate could do that. So if you think that by learning all these manual skills, it's going to make you a really good practitioner, just remember your college buddy who lifted you up and shook you and they were able to do that same skill. So the skill itself is not going to differentiate you, but it's how you think about using that technique or how you apply that technique with clinical reasoning. So I'm going to show you an example here. And this is David Tompkins. He graduated from University of Jamestown last year, and he and his friend Dallas Ermintrout both applied to our residency at South Point. And they're great guys. They had great resumes, great interviews, and so there are 2 orthopedic residents at South Point. So if you ever want to talk to a great guy that is part of a residency program right now, he's doing great, sweating a little bit on all the stuff that he's got to learn, but reach out to David. He's awesome. And so he was my student at Power for 6 weeks last summer, and now he's a resident with us at South Point. So it's been awesome to have him. And he's a great actor, as you can see in that picture. Painful shoulder flexion. So this is a very, very simple example of using clinical reasoning in manual therapy. And so we took a video yesterday too. I put it up on Facebook and Instagram on our Movementologists, @Movementologists social media pages, which I'll have at the end of the presentation too. So if you wanted to see the full video, again, it's very simple, but this is a practitioner using your thought process to decide what am I going to do for manual therapy. So we always prefer to do active intervention first, right? If the patient can do it themselves, that's preferred. So we ask the patient to do it themselves. So I find on exam, he's got some limited shoulder motion and some weakness in shoulder flexion. I want him to be able to kind of stretch that and work that. So I have him actively raise the arm. He's got pain with it. He can't get over that 90-degree angle without pain. So that's our test. 90 degrees active shoulder flexion, painful. He can't do it himself, so I'm going to help him. In this case, I'm going to do, the example we used here is an inferior shoulder glide. So I'm going to mobilize his glenohumeral joint. So I'm going to help him. And then I'm going to have him do it again. And this is perfect world. All of my patients get better. I don't know about yours. Nick, Heather, all your patients get better, right? After you work for about 10 years, then you just never have any problems. So in a perfect world, you pick the right technique. David can get up overhead. I'm talking to him about everything seems to be okay in the shoulder. It's okay to move it. Movement is good. Now that you can raise your shoulder up, now in his mind, he's like, oh, okay, I can move it better. Scott did that thing, kind of got the ball rolling, and now it's moving. And then we start to reinforce it. So now we're back to active. And we say, we didn't have to do that mobilization, but we did it because he couldn't get there. So we helped him, and now he's getting there, and now we reinforce. And this is where self-efficacy comes in. And we really want the patient to feel empowered and that they can take care of some of this stuff themselves. So this is where we're starting to think about the downside of manual therapy, is when we do all of it for them and they don't know how to get there themselves. So we use it as an adjunct to empower them and really say, you don't need me. You might require some help in the next 4 or 5 weeks as we work through this. Eventually, we're going to get you there mentally and physically where you're not going to need me to do that to you. So that's reasoning. I mobilized his glenohumeral joint and he improved. So that's why I chose that technique. I didn't talk to him and say, you have shoulder pain, so let's scrape it with A-stim and let me do a couple stretches. Okay, come back next week and let's see how you're doing. We actually applied a thinking process to that. Okay, if he didn't improve with that mobilization, okay, now I try another one. Now I might do an AC joint mobilization and see if that helps. The point is we want to be thinking through our techniques and not just, if you've heard the analogy of throwing spaghetti at the wall and just hoping something works. And we also want to change the narrative. So we talked about biomechanical effects are only a small piece of what manual therapy does. We need to start getting away from this tissue diagnosis. And one thing that I've kind of struggled with, and maybe Heather can relate, is when people come for needling and they want needling because they have a bunch of trigger points in their neck. And that there might be some evidence for trigger points, but some of it's theoretical and it's all tissue based. Or, my back is out of alignment and I need somebody to put it back in. So we need to start thinking about how do we explain manual therapy in a way that's not so tissue biased? Because if we explain it in a tissue way, the patient might continue to think, well, if my tissue is out of alignment or if my tissue has trigger points, the only thing I can do is go to Scott or Heather and get needle stuck in me or get a manipulation from my chiropractor or my PT. So one thing I heard recently that's pretty cool is we don't need to necessarily convince someone on the first session. And I think sometimes we want to be that hero that explains it and explains it in what we think is correct on the first visit. And we need to convince this person that our way of thinking is right. And that's just not always needed. Sometimes these patients know a chiropractor. I'm just picking on chiropractors a little bit, but sometimes PTs are just as bad. If a patient has been to a chiropractor for 10 years on and off for their back pain, and that chiropractor might be a really trusted healthcare provider in their life, for them to come to me in one visit and say, you know what, your back's not out of alignment, that's a bunch of garbage, everything is fine, you're going to be okay, I'm immediately going to lose credibility with that person because I haven't put in the time to establish that relationship and to be able to tell them that that's probably not correct. One piece of advice I heard recently is, let's take that example. My back is out of alignment. You do a good exam, and then you start talking about why that might be. It could be that your back is out of alignment, but another possibility is this. And so instead of just pushing that away from somebody, because that's what they're holding on to, we're offering more options and giving them time to process it as we start to build trust with that patient. So I just thought that was a really good piece of advice. So think about that as you go forward in your careers. You don't have to be the white knight saving the day with every patient at every single visit. We're just trying to get people to think. If you want to spend some more time tonight, Nicole, glass of wine, an article, put you right to bed. Sticks and Stones, Impact of Language and Musculoskeletal Rehab. We're trying to get away from these words that healthcare providers, including myself, have put in people's head and actually kind of damaged some of their function and thinking because we've used these scary words on the left side of the slide. We want to get towards more positive words or more things that seem like they can be changed. Because if you tell somebody they have bone-on-bone arthritis, the initial thought in my head if somebody tells me that is, there's no way that I can change that. and bone on bone, it's going to be painful. It sounds nasty. Instead, we're using things like narrowing and tightness. You see things on imaging, chronic degenerative changes. Okay, those are normal. Wrinkles on the spine, white hair of the spine, all of those things that you will hear as you go along in your career. And I think you guys will be much more well prepared for this because you'll get it on the front end versus us experienced clinicians trying to make amends for some of those things that we told patients early in our careers. If you get a chance to kind of go through this, these are just more my thoughts on, or my terms that I've tried to break myself of. It's been hard, but I've tried to break myself of saying like, okay, I'm gonna release the trigger points in your muscle. But you try to use a lot of, okay, let's desensitize, let's hit the reset button, let's give this tissue just a stretch to see if we can decrease some of the pain. So just kind of think about some of those alternatives you can use versus using a tissue-based explanation. All right, and we'll wrap up in a couple minutes. I want you guys to remember, be Yoda, not Luke. How many people have seen Empire Strikes Back? How many do we got? Nicole, Holly, Heather, yep, Britta, you're hesitating. Those are the, okay, how about in the comments screen, anybody else? Okay, does everybody know who Yoda is? Britta, do you know who Yoda is? Yes, and most, well, everybody knows who Baby Yoda is. But Yoda is the mentor. Luke Skywalker is the hero of Star Wars. And I think early on in my career, I felt like I was Luke Skywalker. Like I had to go out and I had to like fix everybody. And I was like, the best thing was if I could just manipulate them or get them moving better. And then they'd be like, oh, thank you. Like you did it. You're the hero. I think a lot of us, if you haven't felt that way, I don't know if you're going into the right profession, because I know we want to help people, but try to remember you're the Yoda in the relationship and the patient is Luke. So the narrative is they are on this journey to getting better. Your little green Yoda on their shoulder, hopefully you're not doing that to them in the sessions where you're hanging on their shoulders like that. But you are their guide in the process of healing and recovery. So with that in mind, like we showed in the example with David, manual therapy should be used when we need to step in and show them the way. And so your homework for tonight, aside from reading those articles, Nicole, I'm going to need a report on my desk on Monday morning. You guys can look at this. It's 4.5 minutes and I'm running out of time. But Luke is struggling in his training. Yoda's asking him to lift his spaceship out of a pond. It crashed into a pond. It's all brilliant story. I shouldn't have to be explaining to you this to you, but Britta hasn't seen it yet, so I got to explain it. Just kidding. But Luke is learning how to use the Force. And he's trying to learn how to lift rocks and different items by just using his mind. And I understand this is sounding very nerdy, so I might be losing you. But anyway, Yoda says, okay, lift the spaceship out of the pond. And he can't do it, and he says it's too big, I'm never going to be a Jedi. And so little Yoda, little tiny 800-year-old Yoda, as Luke starts to walk away, raises the ship out of the pond. Is everybody else getting goosebumps right now? Because I sure am. And basically Luke says, like, I didn't think it was possible. And Yoda says, that's why you failed. Brilliant. And so sometimes you got to step in and show the patient it's possible. And that's how I think of manual therapy. It's not this thing we just throw at people and do, you know, I'm just going to, you lay down, I'm just going to scrape on you, or I'm just going to stick needles in you. It's this interactive process that we're trying to show the person or desensitize some pain so that the person can now see, okay, you can move and it's going to be okay. And eventually you're not going to need, Yoda's not going to have to lift the spaceship out of the pond later on because you're going to be able to do that yourself. And if you think of manual therapy in that way, and there's Yoda, and there's Holly and Nicole in a couple of years when they graduate. But you're that Yoda showing them the way. So my goal was to hype you up a little bit. Manual therapy is still a thing. It's always going to be a thing. But we as therapists and PTAs, we need to apply it in a way that shows our training, which shows we're treating humans. We're not just treating the tissue. And we just want to be that guide in their recovery. One thing I want to leave you guys with, and this has helped me in my career. I've really enjoyed and been satisfied with the career I chose. I love what I do. And I think the key is pursuing perfection in what you do, but realizing that you're never going to get there. And that's hard for some people because we have what's called an ego. And your ego will get in your way of growth. But if you are passionately pursuing improvement, it's called a growth mindset. If we're pursuing that perfection and we know in our minds we have a long way to go, you will really enjoy what you do. And that includes reading, networking, going to courses, getting mentoring, all of those things. And if you want to read a really good book about ego, in case you couldn't tell from some of my references, I love reading. This book, Ego is the Enemy, is a great read to get you in the right mindset to enter an awesome career. And so I thank you guys. Feel free to reach out to me if you have questions about an orthopedic residency. I'd love to talk about it. Questions about manual therapy. If you want to follow JJ Ferguson and I on Instagram and Facebook, we post some manual techniques and some exercises and some research. We've been on a little bit of a hiatus because we both are kind of focused on our current jobs, but we're getting back to some education after coronavirus settles down a little bit. So feel free to reach out to me. I love connecting with young people. Thank you for hanging in there for an extra 4 minutes. Watch Yoda lifting the spaceship out of the pond tonight. And if you don't get goosebumps, I don't know if you're human, but let me know. Let me know if you like it. Again, I thank you all. I'll stay on for a few minutes if people have questions, but if not, I know some of you got to pop off. So thank you so much.